Hello, everyone. This is Saud Anwar. I just wanted to talk about an important issue. Today is the 21st of March 2020. It is about 1 a.m. This is about saving healthcare workers in the era of limited personal protective equipment. I'm sure everybody is well aware of the challenges that we are facing across the globe, but specifically in the United States right now, we have a significant challenge with having personal protective equipment. So I want to talk about strategies and then look at what can be done in the current time and then some ways to protect our workforce. This is very real. Again, there were 2,600 some medical workers infected in coronavirus. Many of the top intensivists in Italy have died from this, and there are more people even in parts of the United States who are healthcare workers who are impacted right now. Um, there was a position that was taken initially by the CDC, where CDC had said that this virus is not going to be airborne and it was okay to not have airborne protection. But a few days later, the New England Journal of Medicine on March 17th, this is from my Facebook, where we mentioned about the fact that in a lab model, it was pretty clear that the virus like particles can stay in the air and for about 3 hours or so. And I think that was part of the reason it's important to know that it's airborne, and we have to look at it as airborne to protect the people. That's the reason. And I think CDC is at some point going to reassess their position. They have already changed some of their information on their website after the New England Journal of Medicine information came out on the 17th. But even up, this is from yesterday afternoon, Washington Post, March 2nd, the frontline healthcare workers push back against CDC mask guidelines for coronavirus, which again is exactly what I was talking about on the 17th and 18th. And hopefully we will be not making policies which are not fully accurate, and also make policies that are going to protect the frontline workers, because if the frontline workers are not there, there is no healthcare anymore. This is something that is across the board. I saw this as well, where the Yale New Haven Hospital and literally every single hospital in the state of Connecticut needs the personal protective equipment. And this is a conversation the governor is having every day. I'm having with the governor's team. All the other legislators are reaching out on behalf of the healthcare workers, but the hospitals, that this is part of our challenge. So I think that's why the conversation that I'm having right now is going to have some value and strategies that may hopefully help us out going forward. Uh, Before we even talk about some of the things, important to recognize that cell phones can cause people to get infected because of the fact that they're all over the place. We put them on various tables, desks, locations, and then we put it close to our mouth. So please don't forget that they have to be cleaned as well, especially in healthcare environments, even more obsessively. Another part is there are a number of different things: our cell phones, the keyboards, our cups, things that we drink, our pens. We have to just start to think that anything can be touching the area, can be infected, and sorry, can transmit the infection if we get exposed or touch this. Stethoscopes are something that we have to recognize. Most of these patients will have dedicated stethoscopes, which are disposable stethoscopes that we would have, and that's okay. But if you have a stethoscope at any point, you have to obsessively clean it between one room to the other in the outpatient or inpatient setting. So right now, at this point, all visitors to the hospital must don their masks and then use 62%. These are not N95 masks, just the regular masks. Literally, each and every person needs to have their hands clean and then wear the mask when they enter into the hospital for any purpose whatsoever. And then we have to look at broader management awareness about this. So our mask, the N95 mask, this is actually the Achilles heel of our challenge right now for the healthcare workers perspective and for spread of disease perspective. And I think this is the area that we have to um, look at what are the best possible ways to conserve the masks, but also use them in an appropriate and a safe manner. And then the second piece is going to be the ventilators, which is a different conversation at some point that I will have about managing this challenge. But when we look at the mask, we have to look at the best practices to reduce risk of transmission with the extended use and the limited use of the masks. That's something that we will have a longer conversation about. Is the extended use, what does that entail, and the limited use of N95, what does that entail? Both of these are going to be, hopefully you'll be an expert after our conversation today. When we look at the N95 mask, there's a conventional use. Most of the people who are in healthcare, they know about the conventional use. Pretty much every time we would use an N95, we would actually dispose it off after using it, because we were trying to make sure that we are not spreading any infections through the masks. And once they were used, they were appropriately taken care of. There are powered air purifying respirators that are out there called PAPRs, which can be used. We need to make sure that they are used in the right setting. You cannot use them during surgeries, but you actually can use them when you're managing the patient, and they can be cleaned and used again. So those are some of the things that are going to be there. There are other disposable filtering face piece respirators that are out there as well. That's a conventional situation, but we are moved away from the convention to the contingency status. And in this, we have using expired N95, which actually have been for a shelf life. They're beyond those. And then there is extended use of the same N95 respirator for repeated close contact encounters with several patients. And I'll go over this in more detail. And the limited use of a disposable respirator, the N95, for encounters with multiple patients with doffing. Doffing means taking it off after each encounter. So in one, you just keep the mask on at all times, and the other one, you keep the mask on and take it off and then put it on again for different patients. But in the first one, the extended use, you continue to have the same mask on and use it for several patients. That is in the contingency status, and we are actually functioning at a contingency status at this point already, if not crisis. But it's a matter of time we would be close to a crisis status. And that means that we will be asked to use N95 respirators beyond the manufacturer's designated shelf life, and in the way that are supposed to be used, and use the respirators approved under standard in some other countries that are like N95, but not necessarily proven to be like N95. In other words, they would not be able to have the micron sizes that we are concerned about. And some of the strategies that may come up in future is that excluding healthcare professionals who have a high risk of severe illness from caring for patients who are known, who the physicians or the clinicians are known to have illnesses. For example, if somebody has immunocompromised status, if somebody has a respiratory illness or cardiac issues, they may actually end up not being allowed to care for the patients. That would be a challenge, and that would be sad, because we will need all hands on deck to manage the situation. And then, of course, the ones who have already had the infection, the healthcare workers, and who are thankfully healing and surviving, if you will, they would be able to go back and take care of the patients. And that would be another way to approach this when we are in a crisis situation. So this is something that may become more relevant in some situations, depending on how many people make it through. And then there are all sorts of different options that are being used. And this is why, believe it or not, there is a whole lot of people in all communities, people with engineering background, people with 3D printing capacity, people who are entrepreneurs right now are looking into a few areas. One of those areas is how to get the mask and other personal protective equipment. And there are also people who are looking at ventilators. And then this is something, hopefully our entrepreneurs are going to help us out in this situation before we reach the crisis. We are essentially close to crisis in a matter of a few weeks if we don't have a handle on this situation. The part that we talked about, contingency, the extended use and the limited use, I think it's worthy of a detailed conversation about that. So the extended use, I'll repeat what I had said, that the same N95 respirator is going to be repeated close contact encounters with several patients without doffing, without taking it off. And the limited use is when we actually are using this for multiple encounters, but between those encounters, we take the mask off. So I think that's going to be the difference between the two. And then it's important to know the differences, but also know the pros and cons for both of these options. So some clear understanding whether you're using extended use or limited use is that after we have a high aerosol generating procedures. Now, these masks are there to actually try and protect us from getting the viruses into our airway. If the virus get to into anybody's airway, they would get infected. So following any aerosol generating procedure, which is mainly the biggest procedure, is the intubation procedure, when you protect the airway. Anesthesiologists, other doctors actually do is they put the airway and put the tube into the mouth. That is a time when there's a very high amount of virus that comes out, and we need to have protections to be able to look at that. There are strategies to try and reduce that exposure as much as possible, but after a procedure like that, when you're done, it's important to just get rid of that mask and not use it again. If there is blood or respiratory or nasal secretions, mucus or other secretions on from the patient's bodily fluids on the mask, we need to get rid of that mask. It's not going to be used again. And if you are in a situation where there's a patient with another infection of some kind, that would cause that mask to be a possible transmitter of infection from one patient to the other. This is a different infection. They're multi-infections. That's another reason why you may not want to use the same mask again. And if it becomes difficult to breathe through the mask and it is damaged, you don't use it. So irrespective whether there's a recommendation that you can have extended use or not, when you have any of those conditions, the mask is appropriately disposed of, and that's going to be necessary. So when you look at the extended use, it is somewhat favored, and it makes perfect sense because it involves less touching of the respirator and thus less risk of contact. Every time you touch the mask, you actually are touching your hands with the mask, and that can put first of all, it would reduce your seal, and then that would actually also cause problems. So if you have it there, you're better off keeping it like that in that situation. Therefore, it's a smart idea to have all of those patients in one part of the hospital, and I'll touch about that aspect as well, which is well studied and recognized. And it can be worn for several hours. After about a few hours of that use, you can actually just get rid of the mask altogether, and that's going to be your mask for the whole day, if you will. And that's something that you have to keep in mind, and that's extended use. The limited use is that you can actually have about 5 times you can take the mask on and off, and then it's going to be fulfilled its life cycle. There are some adjustment expectation, there's a storage expectation and labeling and so on that I think I will talk about as well. This is for the limited reuse. If you recall, the limited reuse is a situation where we actually are using the mask, taking it off, and then putting it back again and taking it off and putting it back again about 5 times at the most. So when we adjust the mask, always use new gloves. Do it outside the room. What happens is when you are actually in a situation, you sometimes have to fix the mask. Make sure you fix the mask in advance. And right now, when you're in the middle of the patient's room, you should not be fixing the mask. That gets a little tricky unless it's moved for one reason or the other. Then you obviously have to do it. Prefer to actually make sure that you have new gloves when you do that, because you're trying to protect it. It's not a bad idea to have a regular mask outside of the N95 that people have used. Just reduces the exposure on the outer surface of the mask. It's just a way to protect it, if you will. And it's not a perfect way, but it's just another way to try and reduce the entire exposure. And once you have actually have this, you want to take the mask off. You use new gloves. When you have the new gloves on, you take the mask off in a manner where you are not touching the outside of the mask and also not touching the inside of the mask. The inside of the mask is very critical because that's the part that you are going to be exposed to, so it has to be protected, and you do not ever stack the masks. But when you do that, you're actually putting yourself into a dangerous position, because the outside of one mask is not safe and you put that on the inside of another mask. I mean, I don't think I need to say that to anybody, but I'm just saying it. It's common sense. When we are storing it, it's better to store it in a dry plastic bag if you have to. Dry paper bag, not a plastic bag. And the shape of the mask needs to be protected. So you don't want to make it more efficient and flatten it or anything like that. You actually keep it the way it is, and then you store it for a short time, and make sure that the bag that you're putting it in is labeled. In real world, in the past, we used to, well, this is a new real world, we used to actually just get rid of the mask once you had used it. Now we would not be able to do it for the time being, to try to maximize our potential of using of the mask, and minimizing the waste, if you will, and we are not in ideal circumstances. So never touch the inside of the mask. And when taking the mask out of the paper bag, you need new gloves. And you avoid touching the inside and outside. You do it in a very careful manner. And when you have to put it back on, you actually have to change the gloves again. So if you have to touch it, you touch it on the outside, not on the inside, because the inside is the part to be protected. The outside is going to be considered not clean when you do this. You cannot touch the outside and then the inside once you put the mask the second time around, and you have yourself protected and then covered, and then you have to change the gloves before you continue donning with the other components. So I think these are some things that are worthy to look at from the management of the reduction of risk. Another part I think is worthy to talk about, and this is something that we are probably not doing as much as we should. It is the patient traffic control bundle. And I'll explain to you what this means shortly. So this is something that when we had the SARS epidemic in the past, the hospitals in Taiwan were able to do some of this work, and they were able to, despite very limited resources in personal protective equipment, they were able to reduce nosocomial infections in their workforce. And this was very effective, and I'll walk you through the details of this, and on a one patient situation, but on a multi-patient situation as well. I've modified their strategy a little bit, and I will explain to you maybe why it's necessary to modify this further, because we are dealing with a different coronavirus. We are different patterns, so it's worthy. So if you look over here on the top, what I have done is, this is in my mind, a pink circle. This is the preparation zone. So this is the site to wear special work clothes and work shoes. And this is also the site you're going to change into your home clothes. I think this is important for healthcare workers to actually not, because you don't want your loved ones at your home to get the infection. So you come from your work from your home work home clothes to the workplace, and you have to change into your scrubs and your workplace clothes and the workplace shoes in this situation. And there are multiple sites where there'll be checkpoints and disinfection sites, mainly for hand sanitizing and washing. You wash your hands and you can sanitize your hands. There are different ways. There are different conversations around that topic. I'm just putting cell phone and cleaning the stethoscopes as well, just because we forget that at all times, right? I think it's important because it's so much a part of our life that we actually just pick up the phone all the time without ever cleaning these. That's something I wanted to add. And then there's this purple one as well, which is the PPE placement, which is the donning site where you're actually going to get ready. You need the caps, the goggles, the gloves, the respirator, the gowns, the shoe covers, wipes for your phone and stethoscope and surfaces and so on. So all of those are going to be when you're getting prepared. They're going to be separate locations, separate areas of all of these areas. And then once you have been in that room, you come out of that room, I think it's important to go into the decontamination zone, where you actually are going to take all the caps, the goggles, and all of those things off as well. Now, an important thing I mentioned in the preparation zone is that it's better to use the restroom at this time, early in the game, so that when you are all prepared and you've donned in and you're ready to take care of the patient, getting out at that point is going to be a challenge. I had been listening to some of the Chinese critical care doctors who were there for 6 or 8 hours, and they would not drink anything or eat anything, so that they would be able to be in the place to take care of the patients, because of the actual work that needed to be done to help save their condition and life, but also made less use of the personal protective equipment or waste of it. So I think those are some common sense things we're going to have to look at. Placing the PPE, which is the donning, again, This is you will see some different strategies. I have taken this from the experience from the Chinese more so, and I will have this presentation, and there are videos that are out there as well. But you have to have the special work clothes. They actually started to do this as well, which is a smart thing to do, to have that in advance. And then of course washing your hands is a critical piece of everybody's work and responsibility, that you take care of that, and then put on a disposable cap. After that, you put on the mask, which is the N95, and they actually pushed for N95 in China. I don't know where CDC got their other option. And while they do it, they want to make sure it's protected. The seal is there, and then you actually wear the gloves. And this is something that's different. This is not being recommended in the US, but I think it's a good idea to have inner disposable gloves that a person wears, and then after that they actually would have their protective clothing on top of that. And once they have the protective clothing, they would have a second layer of gloves on, and that's how they would be actually ready for taking care of the patient. You have your goggles in place as well, right about here, and when you're getting your protective clothing in place. So that's how you are setting yourself up for being in the patient's room and making sure you are protecting yourself in the process. The opposite is when you remove it, that is actually decontamination part. You actually take out the outer glove at that time, and this is when it becomes more relevant. And then you actually wash your hands, and in this case, your hands would still have a glove, so you still have your alcohol-based material that you're going to use to clean your hands and the gloves at that point. And then you remove the protective clothing on the outside first. And you do it in a manner, because the outside of that is not clean. You do it such a way that you are not getting further exposed to. You roll it inwards and then hold on to the part that is on the inwards, and then you wash your hands again, or wash your gloves again, and then it's the time you remove your goggles. And in many cases it may be worthwhile to have those protection in place, and these are plastic goggles that you're there. People may want to reuse them, but they would have to be cleaned thoroughly if that would be the case, because of lack of resources. If we had resources, we have been disposing them in the past. And then after that, you actually, and this is going to be in a separate room only, and you're in a different room, you're going to go and remove the mask and then your cap, and wash your hands in every step out of those whole situation. And after that you've done all of those, you remove the inner gloves. Now it would make sense why you had an inner glove and an outer glove. This was making things more efficient. So I think this strategy is a little bit more efficient. That's why I'm proposing this one. And then the other ones, we have taking the gloves in and on and off, adds a little bit of added work, which can put you at a slightly higher risk of infection and chemicals and dust in the air. So I thought I'd just put this out there for the removal of this as well. So back to the conversation we had about the preparation zone, the checkpoint, and the various disinfection sites, and then the PPE placement and the PPE removal sites. So this is what the workflow would be. This is the purple one that we had talked about, that you are already prepared. You have come, you have used the restroom, you have actually, after using the restroom, you have also worn your work clothes and your work shoes. And this is where you're coming into through the stairways and so on. You actually come in and you are washing your hands, making sure that are all safe and clean. And you go to the nurses station, and that's when you're going to wear your N95, and you're going to have all your personal protective equipment. You're going to wear this, and then you're going to go to the intermediate zone. The intermediate zone is the zone where you actually are going to have patients, or the area that may potentially have infection, but not necessarily confirmed case. And then that's after that you're actually going to go to the next one, but you're going to act as if you are in a potentially infected room or contaminated zone before you enter in that area, and that reduces your entire risk for exposure. And then you go finally to the contaminated zone and take care of the patient. And that's the part that is going to be relevant, where you are in the process of trying to be ready early in the game for this area. And these are well marked situations. Now we're talking about one patient's room. Now I'm talking about a healthcare worker going in, but keep in mind, if there's one patient, and many of the hospitals initially will have one patient and will be in a different situation, so that management would require there's a nursing staff that is going to be right outside. Now think about it, that we have been without a pandemic for over 102 years now. If you look at the structure of the hospitals in the ICUs in the past, they were very much focused on what a pandemic would be. And now we have evolved into the entire structure of all intensive care units, which are larger rooms and a single person rooms, which is exactly what we wanted, except that those rooms are not the best situated for a pandemic management because thankfully we have not had this experience. So with this in mind, this is going to be technically a challenging situation. And when a nurse is taking care of a patient, they actually have to go into the room literally every 2 to 5 minutes to take care of either putting new IV line in, new medicine in, looking at the monitors, assessing some of the conditions. So that's what becomes a challenge. So locally, one of the times the nurses have come up with a solution that I'll share with you shortly. Actually, might as well share with you now. This is what the PPE conservation strategy that they have is that they actually, this is the patient's room. They take the IV line tubing all the way out and right outside the room, and this is where the IV pumps are sitting, and your IV line is sitting up here. And we obviously didn't want to have a patient's picture, so this is put in such a manner that the nurses want to adjust the medications. If the blood pressure is changing, you want to go make the blood pressure medicine go up, you are sitting outside the room and you can do it rather than doing it inside. So this is a new technology, if you will, by longer tubes that you can actually just move them outside of the room and make it that way. We've never had to use it this way, but this is a new era. We are going to be able to do this manner. The patient's monitor is getting moved over here as well. You have a monitor inside and you have a monitor on the outside, and this outside monitor is easily able to be looked at. You can actually want to get a blood pressure checked right now. You press the button around here, you can get the blood pressure checked immediately. You're looking at the monitor, you want to get a strip of that, you press the button, you actually can monitor that and print that out. So you have all of those capacities right outside the room for managing the IV fluids, adjusting all of those, and you don't have to physically be in the room at that point, and it saves you about a 2 or 3 or 5 trips every few minutes. And then the ventilator control for some of the ventilators can be moved outside as well. So which actually adjusts your oxygen. You can move it from here, and that is just phenomenal because this is a small little tube, but that is connecting with the ventilator, and you can actually do this in such a manner that you can try to avoid having to go in the room. Now, this does not reduce the quality of care. It just reduces the multiple times going in and out and changing for the nursing staff for going into the PPEs and management of that as well. Now, while we're talking about this, there's another thing that we can do, which is important, and not as many people have done that, but I think it should be done, is we have to do common sense changes in charting. Now, right now, the sad part about what's happened in healthcare is that it's such a highly regulated area that for every minute a nurse is going to spend with a patient, they have to spend about 3 to 5 minutes on a chart. So right now, with the patients being so sick and with the number of patients that is going to increase, we have to have some common sense changes in the charting. And the other thing is that the reason the nurse has to step outside of the room multiple times is to play with the computer, put all the data and information into the computer. And I think that can be done because I'm going to say these patients are in the hot zone or the highly infected zone, contaminated zone. So we want to have the nurses who are in the non-hot zone or the staff be able to do the tele charting for the nurse who is actually right hands on. I think this is a smart thing to do. This is a new era. This is a new challenge. We are in the midst of a disaster. Let's make life simple and reduce the use of personal protective equipment. And also, while we are doing this, let's figure out how we can solve the issues that people have. I think that's something that you have to keep in mind. One of the slides I had missed was in this particular case is you actually have the opposite way. When you're moving out from the patient's room, you actually have to have a decontamination room, and I will go over that again from a different angle. Okay, so we talked about one patient situation. Now we are going to take it to the next level, and this is actually a little bit more important. The next level is, and again, this is from Taiwan as well. They have been able to master this and then have helped people. And then this is a smart thing to start to look into how we can do this. This is more for the hospital entrance in the emergency department. That is where a majority of the patients are going to be coming over to the hospital. And it is important to separate out the patients into the areas which are going to be respiratory areas and non-respiratory areas for the most part. Because unfortunately, every single day in the past, people come in with heart attacks, strokes, other pneumonias, other infections, other cellulitis, and so on. Those things aren't stopping. They unfortunately are coming on as they were before, which was a pretty high level. Now, on top of that, we have a whole new number of diseases. So we want to take care of each and every person coming to our hospitals, and the way to do this is to be able to address these aspects. So there's a hospital entrance. We will look into that for a second. But first things first, the patients who are coming in, and in the triage level, you're identifying the patient. There's a patient who is going to have a pretty much pending diagnosis and high suspicion, and the ones who are going to be positive. So they will actually go into an isolation ward right off the bat, and the other ones will be in a quarantine ward. And practically from the dressing up and the PPE perspective, they're going to be very similar. But it's important to keep them separate, because it will help us make sure that the ones who are in quarantine do not actually get into the confirmed infective zone, because if they do, then we're putting them at a risk. So you might as well have them in a separate area at that time. So you go to the hospital entrance. You're obviously in a different hospital-based clothes, just like you were in the individual cases. And then from there, you make sure when you go to the nurse's station, you are well prepared. Well prepared means that you are actually getting your area that you were checkpoint and disinfection, and then you actually are going to go to the part where you're going to have your personal protective equipment that you're going to get ready at the nursing station right off the bat. This is the entry point. Now keep in mind, this entry point is different from the exit point when you're taking your personal protective equipment off, because that is an area of potential risk of contamination that you can avoid. You go into the transition zone. From the transition zone, you actually check on your quarantine patients, and then you take care of the patients over there if you want, and then go on if you're going to. Just by that time, you have to get into another checkpoint. This checkpoint is again to get cleaned up, but you also have your personal protective equipment. This is the time you most likely will have to have your mask still on. You don't take it off. You go back in, and in the isolation ward, if you have 1 patient or 20 patients, you actually start to take care of all of those and their needs into that area. And that may be the reason you will not necessarily change your the mask and then be able to see everybody, and this would be your extended care mask usage, and you're already taking care of them and making decisions and management. And then you come out and you go to the removing the PPE area, which is an intermediate zone. This is going to be the decontamination area. When you decontaminate, then you leave this area from a different site. So the entry point for the patients is different. The entry point for the hospital workers is different. The entry point within the transition zone and the quarantine ward and the isolation ward is going to be different. And then you exit from there is going to be different. So we create a flow in such a manner that the risk of cross-contamination is decreased, and that actually causes you to have zone A, zone B, or zone C, or red zone, or a yellow zone, or a green zone. Find your local hospital strategies and work in this manner, because this would work, and this would actually reduce the use or waste of personal protective equipment, and people actually, this has been proven to reduce the risk of healthcare worker infection. So I think this is something that we have to start to strategize. Through this, I want to actually ask you, the people who are working in the hospitals, that it's worthy to just ask your hospital administrators and some of the decision makers to listen to this for 30-40 minutes or so. This is going to my conversation, because it may be worthy. Not everybody spent so much time with the perspective, and not everybody has experience some of these things, but because some of Taiwan did experience somewhat of their own epidemic at one point, and they were struggling with the SARS, they actually came up with this, and it works. It's a smarter strategy. The military uses something like this as well. Now in the intensive care unit, so you were talking about the emergency room with a similar same principle. If you're in the intensive care unit, you are actually entering the ICU area. You actually make sure the person is well ready and dressed for the hospital level of the area. Then you actually put on your personal protective equipment at the nursing station area. Make sure you are safe in that, and then you go into the quarantine part of the ICU. And in some cases, we may just have gotten to a point that we may not have a quarantine ward. We may have the entire place become one big isolation ward. If that's the case, it is what it is. You just work with that, and then make sure that you are protecting yourself from getting the infection to others, but also making sure you're not getting the infection yourself. And you manage your patients in that area, and then remove the personal protective equipment from the intermediate zone, and you come out. And after this, you actually leave the ward, go beyond that point, and then you actually are going to go back and change to your home clothes, and you go back home in that same way. And then you can actually protect your family at home. You can actually make sure the fellow workers are protected as well, and the clothes are going to be taken care of within the hospital environment. I think this is a way we can try and streamline and create this process which reduces the risk of infection, and we work with the resources that we have. Even if we work in this manner, we will run out of resources, but I think it's a starting point. So I hope everybody is well. Please take care of yourselves. Please continue the good work that all the people are doing within the healthcare field. This is trying times, but if we do this together and in an organized fashion, we will do well, and so will our patients. Thank you.